muscular dystrophy. Genetic defect, I think you are all familiar with. This is Duchenne muscular dystrophy. It's not mandatory that everything in kids are Duchenne. You should see for that. See, this is a worsened case. You can see the hypertrophic calf muscle. Should see for the hypertrophic calf muscle, and gluteus weakness should be the C. The right one is another picture, same muscular dystrophy, but faciohumeral. Her lower limbs are spared. Her face is involved. She cannot close her eyes and close her mouth. She will close it like this. Otherwise, she cannot close up her own. Faciomuscular, faciohumeral. Different types of muscular dystrophy. The underlying dosha is Vada with Kabhavarana and an unseen Paitiga involvement. So, always beware of that Pitta involvement and undergoing Thadupaga in that. Don't directly target into the Vada and Kabha. Don't give Tikshna Svedas is contraindicated. See the underlying Thadupaga, and mainly it is Vada Kabha Shamana, and Brahmana Chilsa is strictly contraindicated. Physiotherapy is always a part and parcel of this management, and I think just skipped any of the topics, and any doubts? Brahmana is contraindicated because the muscle is getting replaced by fibrous tissue, and increased amount of fat and anything like that can can trigger this manifestation, can worsen the scene. Usually I have seen Shastika Leba and all worsening the scenario within a limited period of 7 days. So, Rukshana Chikitsa is the best drug of option. Ruksha Pralebas and Ruksha Pradeghas will be very useful. We usually do Ruksha Pradeha with Kaulathadi Churna in Dhanyamla. It's very nice. And Shodha drugs internally is mandatory. Better to avoid all Brahmana treatment in that. Externally. Internally, Rasayana drugs should be sought of. We do practice Kanmada Rasayana in that. Kanmada Rasayana in that. Leshinaswarasa with Taila is also advised. Severe other myopathies are the congenital myopathies and all, which happens in very younger stages, but usually in a DMD picture, baby will be more than 4 years to get manifested.
Does absent seizures also cause brain damage, like the seizures or epilepsy with an
Absent seizure is not an epileptic encephalopathy. What's the difference between seizure? Thank you. Seizure and epilepsy. Seizure is only a sign, as like a fever. Epilepsy is a disease. Having several seizures, like I fell down and had a seizure, but I am not having epilepsy. Epilepsy should have an underlying pathology. Absent seizure is surely a result of a brain abnormality, but it's a least possible seizure which can happen. It's a typical absence. I'll be speaking to you and stare in between, and I'll be continuing. I won't lose my tone. My pen in my hand won't drop off. So, baby will be having absence episode in between the class hours and all. While the teacher is dictating the notes, the baby will be having absent seizure. So, he will be here writing down a little bit of the notes. Then he won't be, as he is having seizure, he won't be hearing the some certain amount of note. And after that episode, he will be continuing his writing. So, while seeing his notebook, we can see that absent, and it usually gets precipitated with hyperventilation. So, the clinical scenario is that baby traveling or a child traveling in a bus in the side seat, mama will tell that he won't speak if he is traveling in the bus. Even if I ask questions, he won't speak. If you turn a table fan towards his face, that episode will get triggered. If we ask him to hyperventilate, it will trigger it. Always absence seizure will trigger with hyperventilation, usually. So, it's the treatment line is usually Vadat predominant line.
So if they are under medication with chrono or something, can be parallelly
Sure, every
intervene with the-
epilepsy I do advise to them to have an anti-epileptic if epileptic drug, because if the seizure intensity is more, better safe to have an anti-AED than manage parallelly. If we can manage the epilepsy, then they can taper the AED drug and the results will be very nice. Otherwise also can manage, but should be sure that, damn sure that we are not worsening the epilepsy. It's not mandatory that every time you should direct them for a neurologist and ask them to have an AED, but if you suspect that the seizure frequency is more and severity is more, then better to, it's safe to have an AED and manage parallel. Do have an investigation to identify that underlying cause.
And also, in which stage can we intervene with Tantu Pashan?
Tantu Pashan I am not so confident with. I have given, but I don't give it in each and every seizure. As I told earlier, I am a weak Rasa practitioner. I am not so confident in commenting upon Tantu Pashan.
Thank you.
In our protocol, we do identify the dominant dosha over that and plan the treatment accordingly. As usual, we do the Agni Deepana, do the dosha correction, then make the Niramavastha, give the Krida in Vijarana dose, and before giving the Krida Snehapana, mandatory we go for an EEG. Identify the focus. Then if the focus is generalized, then better go for an AED and add our treatment according.
Madam, if a patient comes to seizure disorder, if they report EEG and even the MRI and the anatomical defect will not be there, still the patient will be having the seizure disorder. In such cases, the patient will be on the antiepileptics. So in such cases, whether we should withdraw the antiepileptics or start Ayurveda, means how we should plan?
Very nice question. The baby is having clinical seizure, but MRI is normal and EEG is normal. That's the scenario. EEG is not a foolproof investigation. An abnormal EEG is a plus point to a clinical picture. A normal EEG doesn't speak out that baby is not having seizure. It's not a 100% foolproof investigation. So even if the EEG is normal, baby can have a seizure. MRI, usually MRI, the quality of MRI depends upon how much Tesla you are doing the MRI. Usually we get a report of MRI in 0.5 Tesla or maximum 1.5 Tesla. Usually focal seizure doesn't come up in 1.5 Tesla MRI. It comes up only in 3 Tesla or much more. So a normal MRI doesn't rule out the pathology. So if the baby is having seizure, you rule out the other extracranial pathologies and then come up to a conclusion that baby is having a intracranial pathology. Clinical seizure, rule out the pseudo seizures. Then another clue is that we can have an EEG in sleep deprivation pattern. That's what we do usually. Baby coming with a clinical seizure, having a normal EEG and a normal MRI, we do sleep deprivation EEG. That's a very nice tool to precipitate the seizure. We do deprive the sleep for 3 hours in last 24 hours. That baby coming to our OP today, then we ask, don't make her sleep, today day don't make her sleep, even today night, deprive her sleep, and tomorrow same time, have an EEG. So maximum 3 hours sleep in a period of 24 hours. So that sleep deprivation is the powerful etiological precipitator. So with having an EEG after sleep deprivation can bring out the underlying pathology. So thank you for the patient listening.